Kia ora, welcome to Stuff Live, another Stuff Live. I'm Rachel Thomas, health reporter, and today we're joined by National Party health spokesperson, Dr. Shane Reti. Morena.
Kia ora mai tātou. Hello
Lovely.
to you too, Rachel. Nice to meet you.
Lovely to have you here. So before we get underway, I want to say, for transparency, we had intended for this to be a debate between Dr. Reti and the Health Minister, Andrew Little. Andrew Little had initially said that he was keen. He came in a couple of weeks ago, spent 30 minutes asking reader questions. At the end of that interview, I asked him if he would be interested in coming back for a debate with Shane today. He initially said yes, he would be keen. Could it be in the morning? He's out of town in the evening. A week later, he backed out, essentially. I did make a final offer to him yesterday, and he sent back a message saying he's out of town today, meeting hospital staff around the country. Addressing the current problems in the health system must be his priority, rather than, with all due respect, having a further conversation with me. He said we had a full half hour of his time, which is true. And then he said, Shane Reti and the National Party have not provided an alternative plan for health and stand for more of the same of the old system. He says, we stand for change because doing more of the same does not improve things. In that respect, our positions are clear. Dr. Reti, your response?
Oh, I'm sorry that you were dismissed in that way. I think there should always be respect between people. And I noticed that he said he's out in the health sector looking at the problems. He's out in the health sector looking at a crisis. Call it what it is. It's a crisis. Everyone agrees it's a crisis. There's no one in the health sector who thinks it isn't. And when you do that, it might seem just like a couple of words, but when you do that, you acknowledge that things are pretty serious. And the sector's looking for an acknowledgement that you're in touch with the sector, that you understand their pain, and calling it a crisis and then moving on with the plan is actually really important. So I'm sorry you were dismissed. I changed my flights. I'm here, ready to front the questions.
So let's be clear, though, this hasn't happened overnight. I mean, workforce shortages existed. The college has been warning about this for years. So if you were Health Minister, what would be your first actions, your first policies, your first funding moves?
So the very first things we need to do is to improve the health workforce. You can have the best policies in the world, but if you don't have a workforce to deploy them, it doesn't matter. So we're going to need to increase the health workforce, and then we're going to need to lift morale. That's got to be a first imperative. And there's a number of ways we can do that. The first thing we could do today is turn on the immigration settings. For example, the most ridiculous, a policy setting that says nurses have to wait 2 years before they can get on the pathway to residency. No one thinks that's a good idea. It defies belief why Andrew and his team think it is. We could do that today. It's a stroke of a pen, and we're very reliant on our international medical graduates. One of the problems, of course, is we're not a welcoming environment at the moment. We're competing with Australia, that $4.5 billion health army. We're competing with Canada, and what do they see? They see a nursing environment which is still under a pay sector freeze from May 5 last year. They see care capacity demand management model, which is the Safer Nursing Accord, which says that so many patients per nurse is what's safe. That hasn't been fully deployed. They see issues with pay equity. We're not a good international environment at the moment, but we could do that at a touch of a pen. Sorry, go ahead.
No, finish your thought.
The second thing we could do is we have doctors and nurses driving Uber Eats. They're permanent residents, their families are here. They've passed the medical council exam and they can't get those intern years, the PGY1s and PGY2s in a hospital. We must be able to figure that out. And then thirdly, we need to turn on the pipeline at our medical and nursing schools, grow our own homegrown, culturally competent doctors and nurses. It just defies belief why in the last budget the cap has been maintained. There was no money for new medical school places next year, which means at earliest it'll be 2024. I just don't understand that.
Okay, and I should have mentioned this earlier, but you may have noticed on screen there is a cutout of the Minister Little. This is in lieu of his presence today, so yeah, that's why that's there. Dr. Reti. Dr. Reti, so how many places would you increase the medical colleges?
So it's capped at about 539. I think there's at least a 20% increase. And I come to that number because the College of GPs in their recent workforce survey says that they want to increase the number of people going through the general practice training program by about 100, from 200 to 300. So 20% of the current capped figure would be an initial starting point, so about 100 new places. But I'd also put a caveat on that because I'm very interested in a third medical school, because clearly we don't have enough capacity with what we've got, and I need a medical school that also focuses especially on rural health. and rural medicine. So I'm interested in the third medical school.
I mean, we talked about this under the previous national government, didn't we? I think one was floated in the Waikato, and that was sort of kiboshed. I mean, haven't we kind of gone through that discussion and realised it's not a good idea?
No, if we look at why it was kiboshed, Bill English put it in the campaign manifesto 2017, and in fact got it through Cabinet. And what the proposal was, a graduate medical school, and it would be built in 3 years. That's how developed it was. Around about February 2018, David Clark rescinded it through the Cabinet notes and decided that what they were doing, rural hubs and other sort of ethereal thoughts, was going to work. How's that gone in the past 5 years?
Can't we simply just bolster the places in the schools we've already got? Why do we need to build a whole new school?
Because they're not servicing the rural community, first of all, and secondly, a new medical school, as we're envisaging it, would be what's called a graduate medical school, which means instead of doing the 5 years like I did, and then another 3, and then another 2, you come in as a graduate and then do an intense 4 years of medical training, like the Americans do, like the Canadians do, like rural Queensland do. So the pipeline switches up, is what the difference would be.
Okay, so how do we fix that 4,000 shortfall in nurses? I mean, you've touched on that a little bit.
Yeah, so 1,000 in aged residential care. Really concerned for aged residential care. I think it's the next sector that's going to break, actually. And then at least 3,000 nurses in the DHB sector. About 10% vacancies in registered nurses, a huge 30% in midwifery. So we can see where the gaps are. Again, we need to look at those 3 buckets. We need to turn on our immigration settings. We've got just under 1,000 nurses, as far as I can determine, who are already here and can't do the CAP course. It's a $10,000 competency assurance program, and that's a hurdle. We should be able to figure that out. And then we need to turn on our nursing schools, turn on the pipeline, figure out retention. Turns out about 25% of nurses in year 1 actually don't proceed. We need to understand why that is. Do we need to wrap more around them so that they can reach the outcome we want them to reach?
I understand Australia pays things like relocation costs, things like that. Would you look at doing something like that for nurses?
We actually are working, we've got a health workforce caucus working on this right now, is what other things we might need to do. And we're very aware of what Australia is offering with relocation costs, housing costs, on top of their salary, and terms and conditions. So we're looking at these sort of things right now, actually.
Okay, so under the previous national government, health spending did not keep pace with expenditure growth. This was the argument of Labor at the time. There was a move to shift more care into the community, but from what GPs have told me, the resources didn't follow. So how would you address that? And it's not just GPs, let's be clear.
So several things. First of all, no country in the world has a health expenditure that keeps up with the need. It's just the nature of health. And I've worked in international environments where the pockets were deep and you could still never get enough health money to meet the need. So that context, first of all. I do believe in the concept of more health in the community. I think that is a mantra and that is a philosophy that we need to be doing more than just talking about. But what needs to happen is the funding and the infrastructure needs to follow the patients into the community. To just download all that sort of work on primary care is not fair unless you fund it appropriately. And my observation over many years has been that primary care has been the dumping ground when things go wrong. For example, ED Middlemore, when that failed, what happened? Well, primary care came to the solution. And so I'm a big fan of increasing the support and capacity for primary care across our health system. In fact, if we look at the health reforms, one of the key premises to make it fiscally viable so that we don't get the $532 million deficit that they finished with about 2 months ago, and ongoing deficits, is that they'll keep people out of hospital and reduce length of stay. That means get them home early. Well, actually, all of that's primary care. You keep people out of hospital through primary care, and if you're going to discharge them early, you better have good community rehabilitation. All of that's primary care. I like that idea. My question is, what is the plan? What is the funding? Who does what? It's nice on a whiteboard. Show me a plan.
Well, exactly. I mean, what is the plan? What is National's plan for that? Do you invest in allied health? Do you invest in physios, counsellors, the wraparound services that we see in the community?
So if we look at Campaign 2020, we were so engaged in primary care that I was prepared to fundamentally change the structure of the primary care team and actually add a social worker to every general practice. It was about to every 5,000, but close enough to 5,000 patients to every general practice. And my observations from many who have worked with a social worker as part of a primary care team, you can do so much more. And so when I look at everything I did in 2020 and put on the manifesto, that was one of the most impactful things, changing the nature of the primary care team so that we could add to their infrastructure, add to the resources that they could provide.
What more could be done in your view at the moment to ease those pressure points on surgical wait lists?
Yeah, well, the worst surgical wait lists in the past decade, from July, where we were 14,000, to April, the latest data, 28,000, worst in the past, doubled in 10 months. How did that happen? We need to understand how we got here, to understand the wait list time. Yeah, we got here, and part of the argument, and Andrew always raises it, no, he's not raising it now, but he always raises it, that it was all due to COVID. No, I'm sorry, that's not correct. You can't use COVID to sanitise bad behaviour and things that have happened.
I think he also blames your previous government too.
Oh, I'll put my hand up to everything we did that was good and not good in the last 9 years. Pin that on me. I will own it. But he owns every one of the last 5 years. So, having said that, if we look pre-COVID from 2017 when we handed over to 2019, let's look at the surgical waiting list, for example. These are people with hips, knees and cataracts who have waited more than 4 months. What we know is October 2017, there were 1,000 people on that surgical wait list. When COVID hit, around about January, February 2020, that had gone up to 7,000, a 600% increase. COVID wasn't even here. How can you blame COVID on that? That was his incompetence, that was his focus on health reforms, and that explains, to a substantive degree in my mind, how we got there. From then to now, COVID did have an impact, I get that. But if he'd have built more ICU beds, maybe we wouldn't have to cancel so many surgical waiting lists and so many outpatient
Well, there's
clinics.
no point in building more beds if we don't have the staff.
So when I say ICU beds, it's actually code for ICU staff. The 5.3 full-time equivalents we need for every ICU bed. I'm meaning the same sort of thing, but none of that was resourced. And so surgical waiting lists were cancelled.
Okay, so let's talk about the health reforms. Would you, if you were Health Minister, roll them back?
What we've said is, and what the sector have told us, is that if we're privileged to be government in 2023, they do not want us to do major structural change. In fact, my own college said, Shane, if you do that, we'll fight you. And I understand the sector's exhausted, they're tired. And so what I've said is when we land, we'll inventory and look around and see what we've got. If something has been successful in the short 15 months, how can we do more of that? So we're not just going to change things just because it wasn't our idea. If the things have worked well, great. How can we help you do more of that? What I do know, and the direction of travel we will have, is when we land, I need to work urgently on health workforce. I need to lift the morale in the sector. And then there'll be other things that we'll be looking at. We'll be looking at cancer. We'll be looking at Pharmac. We'll be looking at waiting lists. We'll be looking at infrastructure. We'll be looking at health workforce. That's what we'll be looking at when we arrive, if we're privileged next year.
What would you do about Pharmac?
Oh, Pharmac has got substantial issues, as the review has shown, and I applaud some of the braveness of the comments and recommendations that came out of the review. I think there's several things here. I don't doubt that Pharmac needs more funding. Pharmac always needs more funding. Medicines always need to be funded more. That's a Shane problem, how to negotiate with the finance spokesperson, the finance minister, to get more funding for Pharmac. But then there's also the process, and we need to explain why our processes, for example, to registration, which on average I hear can be sort of 5 years, why Australia can do it in 18 months and 2 years, why the UK can do it quicker than we can. So I'm very interested in benchmarking our Pharmac processes to best practice overseas. Those will be the sort of things I'll be looking at. How do we get more money to Pharmac, and how do we improve our process and benchmark it?
So shorter wait times to medicines in translation, hopefully?
Oh, that's what I'm talking about. If Australia can do it in 2 years, why do we do it in 5? How do we get to them as a first place?
So today's Stuff has published a story about a letter sent from DHBs a year ago to the Ministry of Business, Innovation and Employment that was asking for more assistance around immigration. The DHBs wanted to get more staff into the country when we had MIQ, and soon after that we saw 300 MIQ spots for health workers every month. So what's your issue with the letter?
My issue is this. This was a warning letter from 20 DHBs a year ago, July 28. And the letter said, we have a health workforce shortage. We have ballooning ED wait times, and we have planned care that is failing its targets as well. We urgently need to have a pathway to residency for nurses and for health professionals. That letter was sent on July 28. Andrew Little told me a few weeks ago that he was only made aware of it a few months ago, like around about May 4, I think he was telling me. We now know that is not correct, because he had to write to me in a ministerial answer saying, actually, I was aware of the letter on September last year. He's then said that, actually, maybe I was aware of the letter, but I wasn't aware of the content. Well, that fails on several grounds. First of all, in the question, I gave him what the content was, so he was aware of it. But secondly, if he wasn't aware of the content, then his defence of incompetence is successful. because if he wasn't aware, he should have been. When he sees in my question 20 DHBs averting a health crisis, he should have urgently said to the Director General of Health, I need to read this letter because it's from important people who know the sector better than I do.
I mean, I suppose in his defence, DHBs, GPs, colleges have been saying crisis for a long time. This is not necessarily new, and at the same time doesn't matter whether he saw the letter, whether he read the letter, whether he knew about the letter, when they acted on the situation anyway.
Well, he didn't act. I mean, all of the points in that letter that Kiana Brookings sent have come home to roost today. Wait times are worst. ED waiting times are worse. We do have a health workforce crisis, and she said in that letter, if we don't address health workforce, we will not avert a health crisis. So even using the words that are sort of contentious here at the moment. So it does matter that he was not aware of that letter, that he somewhat ignored it, and here we are today. 20 DHBs, the CEs of 20 DHBs, they should be listened to. Those are very senior people. Those are your arms and legs, your most senior arms and legs out in the community. They know what he will not know looking through his Wellington office, and that required attention, that demanded attention.
Okay, so we're nearly out of time, but a few quick fire questions I wanted to put to you. We've done the health reforms. Vaccine mandates for health workers, would you keep them?
So what we've said is that we think there are parts of the close contact exemption scheme that are suitable here and now. So what we know from November last year is about 50 doctors who might be mandated, and maybe 700 nurses is what the documentation shows.
621 nurses and midwives, those are the figures we've had from
hundreds. And what we've said is, look, we've got a health workforce crisis, we've got an urgent shortage of these people. Can we take that part of the close contact exemption scheme that says if you have a negative RAT test before you start a shift and you're asymptomatic, then you should be able to return to the sector. That's what we've said, and I think that's a pathway forward for health workers who are mandated out.
So negative RATs, okay.
Negative RAT before each shift and asymptomatic is what the existing close contact exemption scheme says.
Okay. You voted against abortion law reform. Would you touch that reformed legislation?
No, what the leader has said is that if we're successful in 2023, we will not further reform abortion law.
You voted against the end of life choice bill. Which gave us new laws. Would you touch that?
That's up for review in about 2 years, as I recall. So that's already got a legislative process that's in pathway. So nothing to see and do here now. I think the first report from that came out a few weeks ago, and still analysing that small amount of data, but not for legislative review for 2 years. That'll be the time to review that.
Okay. All right. I think that is all we've got time for today. Thank you very much, Dr.
My
Shane
pleasure. Thank you
for
very
coming
much.
in. Hopefully we'll see Andrew Little here shortly.